Our next speaker is Bruno Poliseni from University of Iowa on sensory neural hearing loss. Bruno is a wonderful speaker and a fantastic individual. He's passionate about education, neuroradiology, and head and neck imaging. You're in for a real treat.
Hello, I'm Bruno Poliseni, and for the next 25 minutes, we'll be discussing imaging for sensory neural hearing loss. I would like to thank the organizing committee, Dr. Robson and Dr. Masud, for the invitation to speak at ASHNR 2020, first virtual meeting. As always, this is an honor. This has been a year with many challenges, and the ASHNR has done an amazing job engaging the membership with webinars leading up to this well-organized virtual meeting. I have no financial disclosures. I do have to acknowledge some of my colleagues who have contributed cases for this presentation. So what are the learning objectives? We're going to start with the inner ear anatomy, then we're going to review congenital inner ear malformations, followed by syndromic hereditary etiologies for sensory neural hearing loss, and then we're going to finish with acquired etiologies for sensory neural hearing loss. So let's get started. So this is an MRI of the brain. You see the sagittal T2, where anteriorly in the cistern, you can appreciate the facial nerve, which is thinner than the vestibular cochlear nerve. So the facial nerve is located anterior, and the vestibular cochlear nerve complex is located posteriorly. As you move laterally into the internal auditory canal, you can start seeing the separation in between the cochlear portion of the vestibular cochlear nerve, which is anterior, and the vestibular portion of the vestibular cochlear nerve, which is posterior. As you more into the internal auditory canal, you can then appreciate the smiley face, which shows you nicely the facial nerve, which is located superiorly and anteriorly, the cochlear nerve, which is located inferiorly and anteriorly, and the vestibular nerves, both the superior and inferior one, which are located posteriorly. So this is a nice way to look at for aplasia if the nerves are absent, looking at this sagittal oblique T2. So a way to remember this is 7 up, cochlear is down. So facial nerve is up, cranial nerve 7, cochlear nerve is down, cranial nerve 8. Looking at this coronal CT, you can appreciate this horizontal ridge, which is the Crista falciform, which is going to divide the lateral portion of the internal auditory canal into a superior component and an inferior component. As you look at the axial image, then you can see this vertically oriented bone bar. So we are at the upper level of the internal auditory canal, and this bone bar is going to divide the fundus in the upper segment of the IAC into a anterior opening, and that's the opening for the facial nerve. So that's the facial nerve canal, which is going to have the labyrinthine segment of the facial nerve as it goes into the genicular ganglia. And then the other opening is this posterior opening, and that's the opening for the superior vestibular nerve. So it's going to have the superior vestibular nerve, which is going to innervate the vestibule, the utricle for the vestibule. It's going to also innervate the superior and lateral semicircular canal. As you scroll inferiorly, and you see now the inferior portion of the internal auditory canal, at the fundus, you're going to have 3 openings. The most anterior opening, that's the opening for the cochlear, where the cochlear nerve is going to go into the modilus. Then the second open, which is posterior to the cochlear opening, that's the opening for the inferior vestibular nerve, which is going to have the inferior vestibular nerve innervating the saccule of the vestibule. And the most posterior open in the posterior aspect of the internal auditory canal, that's the singular canal, and that's going to have the ampullary nerve, which is going to innervate the posterior semicircular canal. So there are 4 measurements that I think you should be aware in the inner ear. The first one is this transverse diameter of the bone island at the level of the lateral semicircular canal. Another nice way to use the bone island is you can compare the size of the vestibule with the bone island. The vestibule should always be smaller than the diameter of the bone island. The other opening is the vestibular aqueduct, and that measures in between 1 to 1.5 millimeters. Another way to evaluate the vestibular aqueduct is to compare it with the adjacent semicircular canal. And the vestibular aqueduct should be either smaller or the same size as the adjacent semicircular canal. Here are two other measurements. You have the base of the cochlear nerve canal, and that should measure in between 1.5 and 3 millimeters. So you're going to see in some of these abnormal congenital malformations where there is widening of the base of the cochlear canal. And the internatory canal is going to measure between 2.5 and 8 millimeters. The average is 4. And you're going to see in some of these malformations where there's not full development of the internatory canal, where you have this rudimentary IAC, and the size is going to be decreased. On the coronal planes, at the level of the carotid canal, you're going to see the cochlear. So a nice way to remember here is the C for cochlear, is the C for carotid canal. And here you have the 3 turns of the cochlear. So the apical turn, then you have the middle turn, followed by the basal turn. One important anatomic structure next to the basal turn, that's the cochlear promontorium. That's important because in cases of cochlear aplasia or cochlear hypoplasia, you're going to see flattening of the cochlear promontorium since there is no full development of the cochlear. You can also see here the falciform crest. If you scroll posteriorly, now we're at the level of the vestibule, and the vestibule is at the same level as the jugular foramen. So the jugular vein, so V for vein, is at the same level as the V for vestibule. And you can see here the superior semicircular canal. You can also appreciate here the lateral semicircular canal. Again, showing you the cochlear promontorium. That's going to be an important anatomic structure. And you also have here the cochlear aqueduct. So talking specifically about the cochlear, we're going to start with the modilus, which is located right at the middle of the base of the cochlear here. And then from the modilus, you're going to have the spiral lamina, which is this structure that separates the scala tympani from the scala vestibuli with the periolymph. So the spiral lamina is going to be the structure that's going to separate them. And then separating the turns of the cochlear, you have the interscalar septate. And here you see on the MRI. So you're going to see later on in abnormal incomplete partition where you lose this interscalar septate. So talk about the embryology of the cochlear, so of the inner ear. The inner ear stems from the otic placule that starts developing during the 3rd week of gestation. Then the cochlear is complete developed by 8 weeks of gestation. The vestibule is developed 11 weeks. Semicircular canals in between 19 and 22 weeks. It's important to remember there is a sequence of development for the semicircular canal. The first one to develop is the superior one, followed by the posterior semicircular canal, and the last one to develop is the lateral semicircular canal. After 24 weeks, only the vestibular aqueduct and the sac will continue to grow. The other inner ear structures will be fully developed. The importance of knowing the stage of this development is depending when the insult occurs, you're going to see different appearance of the congenital malformation. So here's a list of the congenital malformations that we're going to go through, and you can see the different stages when this insult will occur. So starting with the Michel's aplasia, which is the interruption of the otic placule development before the 3rd week of pregnancy, where you're going to have complete absence of the cochlear, the vestibule, the semicircular canals, as well as the vestibular and the cochlear aqueduct. So you can see on this image here from this nice paper that was published by Mazon and colleagues on the inner ear malformations, you can see there's complete aplasia of the cochlear. There's no development of the cochlear. There is no development of the vestibule. There are no semicircular canals. You can see the flattening of this wall here due to the undevelopment or the complete not development of the cochlear. So there's no cochlear promontorium. In this case, also had a decreased size. So there's this rudimentary internal canal, and there was also Petrus apex hypoplasia. Otocyst is this rudimentary cyst that will happen right in the middle of the inner ear. That's the only structure that you're going to see, this small cyst. You may or may not have a associated IAC. If you do have, it is going to be a rudimentary IAC, and this insult occurs around the 3rd week of gestation. On cochlear aplasia, there are 2 types. You can have cochlear aplasia with a normal labyrinth, or you can have cochlear aplasia with a dilated vestibule. So in this case here, you can see this large cystic structure, and it's located posterior to where the internal auditory canal would be located, and the cochlear, the expected location of the cochlear would be here. So this represents this dilated vestibule. It is important to differentiate a cochlear aplasia with dilated vestibule from a common cavity. So a couple of things for the common cavity, where you're gonna have some bulging of the wall adjacent to the cochlear, because there's some development of the cochlear. But most important is the internal auditory canal is going to be pointed anteriorly to the cystic structure in cases of cochlear aplasia. In common cavity, the internal auditory canal is going to lead into the common cavity. So you see here an example from the literature in a common cavity where you can see this internal auditory canal is going to lead into this cystic structure, there's not separation in between a cochlear and a vestibule. Cochlear hypoplasia. The abnormality here is that not all the turns of the cochlear are going to be formed. So there is this non-development of all the cochlear turns. For example, in type 1, you're only going to have this bud-like appearance, but as you move on the different types, there is some differentiation of the turns. So like type 3, you have less than 2 turns. On type 4, you have a normal size basal turn, but there's a severe hypoplastic middle turn. So here are 2 examples of cochlear hypoplasia. So I'm going to scroll down on this MRI into the basal turn. So you can see here the basal turn, there's some asymmetry of the members labyrinth, and we're going to count the turn. So start with the basal turn. There's 180 degrees here of the basal turn, and I'm going to scroll up, and you start seeing the basal turn, and you can see 360 degrees of the basal turn. But then as we look at the middle turn and apical turn, there's perhaps only 180 degrees of the middle turn. So there's not a complete development of all the turns. In this other case here on your right, where you can see this CT, I'm going to scroll down here again to the basal turn, and here's the basal turn. We're going to count the turns. So 180 degrees of the basal turn. So we're going to scroll up, and you can see the basal turn going up. So there's 360 degrees at the basal turn, and now we're going to see the middle turn. So there's 180 degrees, and there's probably almost 360, and there's definitely no apical turn. So there's not a full development of all the turns. So that's what you look for when you're looking at cochlear hypoplasia. And this is going to be different from incomplete partition, where actually all the turns, so the members labyrinth has developed, but there's not going to be a partition in between the turns. So you're going to have fusion in between the turns. So starting with the incomplete partition 1, which results from this interruption of development in the 5th week of pregnancy. This is also known as the cystic cochlear vestibular malformation. So the cochlear show complete absence of the modulus, and there is this cystic appearance, this bulbous cystic appearance of the cochlear without any internal architecture. There is also dilatation of the vestibule, and that gives the resemblance of a figure 8. So that's incomplete partition type 1. And incomplete partition type 2, which is the most common, accounts for 50% of all malformations. It happens, the insult happens later in the development, about 7 weeks of gestation. So what you see is a fusion in between the middle and the apical turn. So the turns are there, they're just completely fused. You're going to see there is a basal turn that can be identified. This can be associated with a triad where you're going to see this abnormal cochlear with the fusion of the middle and apical turn, a dilated vestibule, and a dilated vestibular archaduct. And this is known as Mondini malformation. The third type of incomplete partition, this is not the same as the prior etiologies, where there's this interruption of the development at a specific age of the gestation. This is an inherent genetic malformation where there is a gene associated with this malformation. This is a POU3F. This is usually affect males, and you're going to have mixed hearing loss with this rapid progression. There is total absence of the modulus, though you can see some interscalar septum. So the cochlear and the internal third canal, you're gonna have this dilatation, and this is also known as this X-link Stapes gusher. So walking through these malformations can be challenging due to the different nuance of each one of them. So this diagram by Kirk and colleagues, really nice to walk you through them. So you start by, is there any inner ear structure? So if you don't see any inner ear structure, you know you're dealing with a Michel's anomaly. If you do see a normal or malformed vestibule, but there's absence of the cochlear, then you're dealing with a cochlear aplasia. Then when you look at the inner ear structures, if you don't see a separation between the cochlear and the vestibule, you're dealing with a common cavity. If you see a separation, what's going to guide you is the development of the cochlear. If you don't see all the turns of the cochlear and the cochlear is smaller, you're dealing with a cochlear hypoplasia. If you see a normal size cochlear, but there's fusion in between the turns, you're dealing with the incomplete partition. So this is a nice way to have a systematic approach of this abnormalities in the inner ear. So moving to the hereditary etiologies of hearing loss, this accounts for approximately 30% of these malformations. The other 70% are non-syndromic. There is a list of syndromes that can cause inner ear malformation. Here are some of the examples, and I'll show you some of the images findings in some of these syndromes. Starting with George syndrome, which is a combination of head and neck, cardiac, CNS, and genitourinary disorders. What you see on imaging, you're going to have choanoatresia here. You see on the left side the choanoatresia. There is esophageoatresia. There is a cochlear dysplasia, and there is bilateral coloboma. In Waardenburg syndrome, hearing loss is the most common feature. There is a list of abnormalities that you're going to see in the inner ear. And so here are some of them. You see on the right side, there is decreased size of the inner ear. Compare that to the left side. There is also dilatation of the vestibular archaduct. As we discussed earlier, you compare the size of the vestibular archaduct with the adjacent semicircular canal, and you can see this vestibular archaduct is enlarged. A nice way to measure the vestibular aqueduct is this oblique view where you can see, you can measure the size of the aqueduct. You also have here a dysplastic vestibule as well as an absence of the posterior semicircular canal. And then the third syndrome I want to share with you is the Branchio-oto-renal syndrome, which can cause sensory hearing loss or mixed hearing loss. There is a list of abnormalities that you're going to see, specifically in the inner ear. What you're looking for is this unwound appearance of the cochlear, where the middle and the apical turn are going to be offset anteriorly and hypoplastic in relation to the basal turn. So you compare this with a normal case where the middle and the apical turns are more center in relation into the basal turn. You can also see here the funnel shape of the IAC and the medialized facial canal. This patient also had ossicular chain malformation. So moving to other etiologies that can cause inner ear, sensory neural hearing loss, abnormalities in the bone can lead to sensory neural hearing loss. So otosclerosis is one of them, where you have osteodystrophy of the otic capsule. Specifically for sensory hearing and sensory neural hearing loss, we're looking for retrofenestral otosclerosis. What do you see in retrofenestral otosclerosis? So this is pretty characteristic of retrofenestral otosclerosis, where you see this lucency surrounding the cochlear bilateral. Here you see the lucency surrounding the cochlear consistent with otosclerosis. If you do an MRI and you give contrast in this case, you're going to see the abnormal enhancement along these areas of abnormal bone. Other bone etiologies that can cause hearing loss, Osteogenesis imperfecta has hearing loss as an important clinical feature. What you see on imaging is this decreased density in the bone structures in the otic capsule, so surrounding the cochlear. This is in the differential diagnosis. This bone findings surrounding the cochlear is in the differential of otosclerosis. However, the extension, there's much more extensive bone change with osteogenesis imperfecta. You can see here at this level, you're seeing part of the skull base because of this basilar impression due to the softening of the bone related to osteogenesis imperfecta. Paget's disease can also cause sensory neural hearing loss, so it's another bone cause for sensory neural hearing loss. So to finish up in the last couple minutes, I'm going to talk about acquired sensory neural hearing loss. So starting with traumatic, you can have a fracture along the temporal bone that can cause a sensory neural hearing loss. There's neural labyrinth here. Superficial siderosis, as you can see here, there's hemorrhage along the fovea, so chronic hemorrhage along the fovea. Remember, when you have superficial siderosis, to image the entire neural axis. So this 41-year-old, we got an image of the entire neural axis, and there was a pseudomeningocele in the. This patient had surgery in the spine, and this recurrent bleeding caused the superficial siderosis that led to sensory neural hearing loss. Vestibular schwannoma, the most common cause of neural hearing loss. They can also be located in the cochlear. There has been studies, and we did this one comparing the accuracy of KISS and post-contrast, and you can see we had very good accuracy looking at the KISS without the post-contrast. The ones that it's a little more challenges when the lesion is located in the inner ear structure. So here you see in the vestibule, and this is another one located in the cochlear. Other etiologies for in the inner ear, in the internal auditory canal, this is a meningioma with the characteristic calcification. This is a lipoma, saturated in the post-contrast. You can always use the mucosa to see if you're dealing with a pre or a post-contrast. You see the nice enhancement in the post-contrast. You can have cisternal lesions that can cause compression of the nerve, arachnoid cyst, epidermoid, and you can also have Peters apex lesions. So to finish up with my last slide, infections etiology is a common, sensory neural hearing loss is a common complication of infection, meningitis or labyrinthitis. In this case, you see here the labyrinthitis ossificans with the calcification in the cochlear. So in summary, we reviewed the inner ear anatomies. We went through a differential for congenital inner ear malformations, show you some examples of syndromic hereditary lesions, and finish up with acquired etiologies. Thank you very much for your attention. Be safe. Hope to see you next year, hopefully in person for ASHNR 2021. Thank you.
Our next speaker comes from Mayo Clinic in Arizona, Dr. Joseph Hawksworth, who's going to be talking to us on glossopharyngeal and hypopharyngeal dysfunction.
I'm grateful for the kind invitation to join you today to discuss glossopharyngeal and hypopharyngeal dysfunction as pertaining to cranial nerves 9 and 10. I have no disclosures to make for this lecture. The pharynx is really at the crossroads of speech, swallowing, and respiration. These functions must act in perfect coordination as they are anatomically intertwined. Radiology plays an important role in the diagnosis of pharyngeal dysfunction, but knowing clinical history is critical to selecting the most appropriate imaging strategy since there are numerous causes of pharyngeal dysfunction. For today's discussion, we're going to specifically focus on imaging in patients who have a suspected 9th or 10th cranial nerve palsy as a cause of their pharyngeal dysfunction and/or throat pain. In addition to requiring thorough knowledge of the anatomic, physiologic, and pathologic features of the cranial nerves, one must appreciate that detailed clinical information is necessary for tailoring the examinations, locating the abnormalities, and interpreting the imaging findings. Our goal today is to review the anatomy of the glossopharyngeal and vagus nerves, and then reinforce these concepts through a segmental case-based pathology presentation. Because hoarseness will be covered at length as a separate lecture during this session, our discussion of the vagus will be limited to high vagal lesions in an attempt to limit redundancy. The glossopharyngeal nerve is comprised of motor and sensory fibers. The efferent motor fibers of the glossopharyngeal nerve supply the stylopharyngeus muscle, which helps to elevate the larynx and expand the pharynx during swallowing. General somatic afferent fibers convey sensation from the posterior third of the tongue, tonsils, medial aspect of the tympanic membrane, and the eustachian tube. Special afferent fibers convey taste from the posterior third of the tongue. Lastly, through a somewhat circuitous pathway, the glossopharyngeal nerve provides parasympathetic innervation to the parotid glands. The glossopharyngeal nerve leaves the medulla as 3 to 5 filaments that originate from the upper third of the post-olivary sulcus. These filaments coalesce and course forward and laterally on the anterior side of the flocculus and choroid plexus. Ultimately, the 9th nerve enters the more medial pars nervosa of the jugular foramen with the inferior petrosal sinus as highlighted in yellow in the top image. At the site where the intrajugular ridge of the temporal bone meets the carotid ridge, the tympanic canaliculus is directed upward and transmits Jacobson's nerve to the tympanic cavity. This is the pathway through which the afferent sensation from the middle ear and medial surface of the tympanic membrane is received, and it's also how the parotid parasympathetics reach the tympanic plexus and eventually the lesser petrosal nerve. The vagus nerve features the most extensive course and distribution among all cranial nerves, coursing through the neck and traversing into the thorax and abdomen. The efferent motor fibers of the vagus nerve supply all striated muscles of the larynx and pharynx except for the stylopharyngeus and tensor veli palatini. The vagus nerve receives sensory input from the larynx, pharynx, external auditory canal, lateral aspect of the tympanic membrane, and the meninges of the posterior fossa. It receives general visceral afferent information from and provides parasympathetic innervation to the pharynx, larynx, thoracic, and abdominal viscera. And last, and most certainly the least important function that we could all live without, it receives taste sensation from the epiglottis. The nerve emerges from the medulla between the olive and the inferior cerebellar peduncle, adjacent to the glossopharyngeal nerve, entering the pars vascularis of the jugular foramen. Which you can see here in yellow is the larger, more posterolateral component of the jugular foramen that also contains the jugular bulb and transmits the accessory nerve. Arnold's nerve arises at the level of the superior vagal ganglion and provides sensory innervation to portions of the external ear, which it reaches by extending from the jugular foramen through the mastoid canaliculus, highlighted by the yellow arrow here, to the descending facial canal and ultimately exiting via the tympanomastoid fissure. When trying to apply the concept of pars nervosa and pars vascularis to high-resolution imaging, I've often felt that like this was an oversimplification. This led me to read some of the neuroanatomy work of Dr. Roten, so I'd really like to spend the next few minutes talking about the jugular foramen anatomy in greater detail. The jugular foramen is difficult to conceptualize because it has a complex irregular shape that's highly variable. The margins of the jugular foramen are formed by the petrosal part of the temporal bone, which is shaded in red here, and the condylar part of the occipital bone, which is shaded in purple. To orient ourselves, we'll review this anatomic dissection, which is viewed from posteriorly with the brainstem removed. We will focus on the area designated by the oval initially. The dura over the jugular foramen has two characteristic perforations, a glossopharyngeal meatus through which the glossopharyngeal nerve passes, and a vagal meatus through which the vagus and accessory nerves pass. These meatus are consistently separated by a dural septum that ranges in width from 0.5 to 4.9 millimeters and is annotated here by the yellow arrow. More dura has now been removed to expose the sigmoid and inferior petrosal sinuses, which are labeled for your reference. Dr. Roten describes the jugular foramen as being divided into three compartments by the dura mater. The two venous compartments consist of a larger posterolateral sigmoid part, which receives the flow of the sigmoid sinus, and a smaller anterolateral venous channel, the petrosal part, which receives the drainage of the inferior petrosal sinus. The intrajugular part, through which the 9th, 10th, and 11th cranial nerves course, is located between the sigmoid and petrosal parts at the site of the intrajugular processes of the temporal and occipital bones, which are highlighted here in orange. Note that the nerves penetrate the dura on the medial margin of the intrajugular process of the temporal bone to reach the medial wall of the internal jugular vein. As a result, these three nerves are intimately related as they pierce the dura. This subtle anatomic point was initially lost on me when only thinking in terms of pars nervosa and pars vascularis. The external aperture of the cochlear aqueduct opens into the anterior apex of the pyramidal fossa as highlighted by yellow arrows. These are very useful landmarks to find the glossopharyngeal meatus, which is just below this. At this point, you can see the glossopharyngeal nerve entering this fossa and then directing anteriorly. Slightly more inferiorly, you can see the vagus and accessory nerves enter the separate vagal meatus. As depicted in the sagittal plane, you can again see the glossopharyngeal nerve turn abruptly forward relative to the pyramidal fossa, which is shown by the yellow arrow. In contrast, the vagus nerve exits the jugular foramen more vertically, retaining an intimate relationship to the accessory nerve. Let's look at this anatomy on post-contrast MRI of the right jugular foramen with the internal carotid artery and the jugular bulb highlighted with color for your reference. First, the glossopharyngeal nerve pierces the dura and courses anteriorly. Next, it is followed by the vagus and accessory nerves piercing the dura more inferiorly. The flow void of the inferior petrosal sinus confluens is then seen draining into the jugular bulb with cranial nerve 9 anterior, while 10 and 11 are posterior. Lastly, we have cranial nerve 9 anterolateral relative to the internal carotid artery, while 10 and 11 are joined posteromedially by the 12th nerve as it exits the hypoglossal canal. Continuing extracranially, the glossopharyngeal nerve courses along the stylopharyngeus muscle, which is annotated by the yellow arrow. It ultimately penetrates the pharynx wall just above the level of the middle constrictor muscle to form the pharyngeal plexus. It also branches to the posterior tongue as it extends medial to the hyoglossus muscle, which is highlighted in orange here. Motor fibers leave the vagus nerve as three main branches: the pharyngeal branch, the superior laryngeal nerve, and the recurrent laryngeal nerve. I anticipate that the latter two will be discussed in detail during the lecture on hoarseness in the session, so we'll focus on the former. The pharyngeal branch of the vagus nerve, the principal motor nerve of the pharynx, arises from the upper part of the nodose ganglion. It passes across the internal carotid artery to the upper border of the middle pharyngeal constrictor, where it divides into numerous filaments to help form the pharyngeal plexus. Although we do not routinely attempt to image these tiny branches, the area from the carotid sheath through the pharyngeal constrictor should be scrutinized for lesions on imaging. When paralysis of cranial nerve 9 or 10 is identified clinically, complete evaluation of these nerves from their brainstem nuclei to their end organs must be performed. For purposes of organization and discussion, this can be accomplished by considering the nerves in 7 segments, as has been previously described by Blitz and colleagues. However, for simplification, we will lump some of these together and perform a case-based review of pathologies affecting the 9th and 10th cranial nerves as 4 segments. It should be noted, however, that some lesions may affect the nerves in more than one segment. We'll begin with the brainstem segment. As pertaining to involvement of cranial nerve nuclei, Waardenburg Syndrome is caused by an insult to the lateral medulla, usually from a Paget territory infarct. Importantly for our discussion today, clinical features include hoarseness, dysphonia, dysphagia, dysarthria, and a decreased gag reflex due to 9th and 10th nuclear involvement. However, the multitude of other clinical deficits listed here usually makes lesion localization of the brainstem relatively straightforward. Multiple sclerosis can certainly involve the brainstem and is reported to affect 30% of patients in this area at the time of disease onset. The pons is the most commonly affected site, followed by the midbrain and less commonly the medulla. Lesion distribution in demyelinating diseases may actually be helpful, particularly in the setting of a new presentation with 9th and 10th cranial neuropathies. For example, there is some data to suggest that a dorsal medullary lesion, such as the example here, is more common with neuromyelitis optica than with MS or ADEM. Primary hemorrhage of the medulla is relatively rare. Brainstem hemorrhage is often restricted to the pons, for which hypertension and vascular malformations are the most common causes. This is an example of a known small cavernous malformation that recently hemorrhaged and is very well positioned to involve the nuclear and parenchymal fascicular components of left cranial nerves 9 and 10. Metastases, gliomas, and lymphoma are the principal neoplasms to affect the brainstem and lower cranial nerve nuclei, though others such as ependymoma and hemangioblastoma can do so as well. The nerve palsy can be bilateral if the tumor is midline, affecting both nuclei, or unilateral when the lesion is eccentric, as in this case of a grade 3 anaplastic astrocytoma that presented as a lateral medullary lesion with faint associated enhancement, and ultimately on follow-up imaging grew to become much larger, unfortunately for the patient. Next, we'll discuss some pathologies affecting the short but important cisternal segments of the 9th and 10th cranial nerves as they extend from the medulla to the jugular foramen, which is typically only a length of about 1.5 to 2 centimeters. Lymphoma and carcinoma can present with leptomeningeal dissemination, which can lead to multiple cranial neuropathies. In this case of extensive leptomeningeal disease, the 9th, 10th, and 11th cranial nerve complexes are matted and thickened as shown by the arrows. CSF cytology ultimately confirmed B-cell lymphoma. Approximately 40% of schwannomas occur in the head and neck, and they can originate from any cranial nerve, including 9 and 10. The clinical manifestations of these tumors are highly variable, depending on tumor location, size, and growth pattern. Additionally, they frequently span more than one cranial nerve segment, as can be seen with this glossopharyngeal schwannoma that's primarily cisternal, but beginning to enter the jugular foramen, which is denoted by the arrow. Likewise, we can use this small meningioma to revisit some anatomy as it is both cisternal and foraminal. If we try to seek out how this patient could present with involvement of the 9th, 10th, and 11th cranial nerves, we can very clearly see tumor extending both the glossopharyngeal meatus and the vagal meatus. Note the normal anatomy on the contralateral side. Clival chordomas can produce lower cranial nerve palsies as they extend to involve the skull base, or if they have an eccentric component by abutting the nerves in their cisternal segments. In this case, as referenced by the circle, the left jugular foramen was relatively spared by tumor, but the severe medullary compression is also causing significant traction on the cisternal segments of the lower cranial nerves, in addition to the marked compression of the brainstem. Various infectious and inflammatory processes that have a predisposition to affect the cisterns around the brainstem can also cause lower cranial nerve impairment, particularly granulomatous diseases. Tuberculosis and fungal infections preferentially cause basilar meningitis, which can lead to cranial nerve palsies in approximately 20 to 30% of patients. This is a case of coccidiomycosis meningitis, which is endemic to where I live in Arizona. The classic finding on brain MRI is leptomeningeal enhancement on post-gadolinium imaging that is characteristically localized to the basal cisterns, but can also be more diffuse. Note the extensive thickening and enhancement along the 9th and 10th cranial nerves. Sarcoidosis frequently affects the central nervous system, with symptoms from leptomeningeal involvement being the most common manifestation, present in 40% of patients. Any cranial nerve can be involved. This case shows quite severe generalized leptomeningeal disease on the sagittal image below, with marked abnormality along cranial nerves 9 and 10 as encircled here. Any process that can lead to enlargement of the vertebral artery or pica has the potential to produce 9th and 10th cranial nerve symptoms attributable to compression. This includes dissection, dolichoectasia, aneurysms, and arteriovenous malformations. These axial and coronal CIS images demonstrate a large fusiform proximal basilar artery aneurysm compressing the cisternal segments of the 9th, 10th, and 11th nerves as they course toward the jugular foramen, as highlighted by the arrows. Glossopharyngeal neuralgia is a neurovascular compression syndrome characterized by severe paroxysmal episodes of pain localized in the posterior tongue, tonsil, throat, or the external ear canal. The overall incidence of glossopharyngeal neuralgia appears to be considerably lower than that of trigeminal neuralgia, potentially related to the more proximal location of the glossopharyngeal transitional zone, where there is increased mechanical vulnerability to compression. The posterior inferior cerebellar artery is the most commonly responsible vessel for the nerve compression in the supraolivary facet, with compression of both the 9th and 10th root entry zones by a pica loop shown by the arrows on these coronal and axial T2 space images. Because symptoms are not always straightforward, imaging must also exclude a neoplasm in the pharynx or larynx or other causative lesion. Next, we will review some imaging examples of pathologies affecting the skull base in the vicinity of the jugular foramen. In the head and neck, paragangliomas are slow-growing, hypervascular lesions arising from non-chromaffin cells of neural crest origin. They are most commonly located in four main sites: the carotid bifurcation, the jugular foramen, the middle ear cavity, and along the cervical portion of the vagus nerve. CT may be helpful in demonstrating an aggressive moth-eaten pattern of jugular foramen bone erosion. MR imaging better defines the underlying soft tissue mass, including, as in this case, the extension of the paraganglioma to also involve the middle ear cavity. If the lesion is large enough, a salt and pepper appearance has been described, typically on spin echo-based imaging. The salt, shown as tiny foci of T1 hyperintensity in the upper image, represents slow flow versus hemorrhage, and the quote-unquote pepper represents dark flow voids within the mass, better seen on the lower T2 image. The classic angiographic appearance of a paraganglioma, described with digital subtraction angiography, as a hypervascular mass in a typical location with intense tumor blush early on and early visualization of draining veins, as seen on this lower transorbital oblique image. Comparable features have now also been recognized with contrast-enhanced MRA, shown in the top image here. The combination of conventional MR imaging and contrast-enhanced MRA has been shown to be significantly superior to conventional MR imaging alone for the diagnosis of paragangliomas, with a much higher specificity. So this could be a useful sequence to consider adding when evaluating a mass that could potentially represent a paraganglioma. As previously mentioned, schwannomas can arise from the cisternal, foraminal, or extracranial portions of these nerves, but often have a dumbbell morphology when centered on the jugular foramen, as in this case. As opposed to paragangliomas, extension to involve the middle ear is not a feature of these tumors. Cystic change is frequently associated with schwannomas, leading to T2 heterogeneity seen on the upper image. Enhancement can also be variable, depending on the proportion of Antony A and Antony B cells seen histologically, as well as the overall degree of cystic degeneration. These schwannomas cause expansion and remodeling of the jugular foramen without a permeative pattern of osseous destruction on CT. The lower angiogram also demonstrates an expected hypovascular appearance for schwannomas. Meningiomas, which are the third most common jugular foramen mass, arise from arachnoid cap cells found along cranial nerves within the jugular foramen. Unless found incidentally, these tend to be relatively large at presentation when the size has become sufficient to compress cranial nerves 9, 10, and or 11. As shown by this example that's centered on the jugular foramen with a dumbbell morphology, meningiomas usually manifest enhancement on post-contrast T1 weighted images and often have associated quote-unquote dural tails. Signal on T2 weighted imaging is relatively hypointense due to their dense fibrous composition. CT of meningiomas located around the jugular foramen often demonstrates sclerosis, which, together with the lack of vascular flow voids, is helpful in differentiating these tumors from paragangliomas. Additionally, angiography typically demonstrates avid enhancement that characteristically persists well into the venous phase of the run. Metastatic disease can also affect cranial nerves by perineural spread or skull base involvement. Lung, prostate, and breast neoplasms tend to be the most common associated primary neoplasms, reflecting their high overall prevalence in the community. Some reports have described cranial nerve palsies associated with skull-base metastases as the presenting symptom in approximately 25 to 30% of patients. MR imaging is the best modality to demonstrate marrow replacement and an enhancing skull-base mass, as in this case. In contrast, CT is complementary, better demonstrating the pattern and extent of osseous destruction. This example of metastatic renal cell carcinoma underscores the importance of including metastasis and plasmacytoma in the differential diagnosis of a destructive skull-base mass presenting with an initial lower cranial neuropathy, even in the setting of a previously undiagnosed systemic malignancy. Nasopharyngeal carcinoma is another malignancy that can extend to involve the skull base, producing lower cranial nerve symptoms. This tumor originates in the high posterolateral nasopharynx just below the skull base. Based on the 8th AJCC staging system, nasopharyngeal carcinoma with associated skull base involvement but without cranial nerve involvement is considered a T3 lesion. If, however, there is intracranial extension or cranial nerve involvement, it's considered a T4 lesion. MR imaging is significantly more sensitive than CT in demonstrating skull base involvement and intracranial extension, as seen with this tumor that is extending posterolaterally from the nasopharynx into the right jugular foramen. Skull-base osteomyelitis may occur as a complication of paranasal sinus or ear infections, typically encountered in the immunocompromised patient. Patients can present with an isolated lower cranial nerve palsy without obvious signs of infection at times. CT optimally demonstrates the osseous skull-base destruction, but MR imaging better demonstrates the associated soft tissue inflammatory changes, the extent of marrow involvement, and intracranial complications if present. Here you can appreciate the extensive enhancement within and inferior to the left temporal bone to the level of the jugular foramen in an 82-year-old who initially presented with hoarseness and dysphagia, but no overt clinical signs of infection. Additionally, he did not have any exam findings of necrotizing otitis externa. FNA of this inflammatory phlegmon mass ultimately confirmed a Pseudomonas infection. Head trauma as well as iatrogenic injuries are also important considerations that can be associated with 9th and 10th cranial nerve palsies. Because of the close proximity of the occipital condyle, hypoglossal canal, and jugular foramen, mixed cranial neuropathies are quite common. This high-resolution CT nicely depicts occipital and temporal bone fractures that ultimately propagated into the posterior and superior aspect of the left jugular foramen. Lastly, we will turn our attention to extra-foraminal cranial nerve lesions that can lead to pharyngeal dysfunction or pain. Again, because of the upcoming lecture on hoarseness in this session, we'll limit this discussion to the suprahyoid neck to decrease any redundancy. Eagle syndrome is an aggregate of symptoms including recurrent throat pain, foreign body sensation, dysphagia, or facial pain as a result of an elongated styloid process or calcified stylohyoid ligament. The pain in Eagle syndrome resembles that of glossopharyngeal neuralgia, but is generally more constant and dull than episodic. It has been subsequently hypothesized that the pain of Eagle syndrome results from compression of the glossopharyngeal nerve by an elongated styloid process as it passes over the superior constrictor muscle. However, styloid process length alone does not appear to correlate with the severity of symptoms. One study in 2015 in the head and neck literature found that the styloid process was significantly closer to the tonsillar fossa in patients with Eagle syndrome compared with controls, while no significant differences were found in other measures such as styloid process length or angle made with the skull base. As such, the authors proposed that the distance to the tonsillar fossa may be a more appropriate diagnostic criterion for Eagle syndrome than styloid process length and may contribute to the pathophysiology of Eagle syndrome. The potential for morbidity following resection of a vagal schwannoma is significantly higher than that for sympathetic chain schwannoma, so preoperative determination of the nerve of origin is important. Historically, it's been emphasized that vagal schwannomas more commonly splay the internal carotid artery and jugular vein, though this can occasionally be seen with sympathetic chain schwannomas too. The neurosurgery paper referenced here from 2017 emphasized the importance of also looking at relative medial or lateral displacement of the internal carotid artery. On the top image, the carotid and jugular are splayed with medial displacement of the carotid, so this would suggest a vagal origin. In the bottom image, the carotid and jugular are displaced together with slight lateral carotid bowing consistent with the sympathetic chain origin. We must certainly not forget about more common masses involving the end organ as a cause of pharyngeal pain or dysfunction, such as this example of squamous cell carcinoma of the oropharynx, as shown in this case on axial CT and coronal T1 weighted MRI. An endophytic tongue-based mass could certainly affect the glossopharyngeal nerve as it courses along the inner aspect of the hyoglossus muscle, with the normal muscle highlighted on the left for your reference. Dissection of the internal carotid artery, which is usually associated with hemicranial headache, Horner syndrome, and cerebral ischemic symptoms, can also present with lower cranial nerve palsies. For reference, note the intimate location of this carotid pseudoaneurysm to the stylopharyngeus muscle, which is designated by the arrow and can be used as a reference for the course of the glossopharyngeal nerve. In summary, when a patient presents with pharyngeal pain or dysfunction with signs and symptoms of a glossopharyngeal and or upper vagal palsy, it's critical to perform high-quality imaging from the brainstem through the end organ, which is the tongue base and pharynx for the purpose of today's discussion. In order to perform and interpret these exams, we must know the cranial nerve anatomy in detail. In addition, many of these patients will suffer from multiple cranial neuropathies, so knowing the clinical history is critical, as it can really help us perform a more accurate imaging-based lesion localization. Thank you so much for your time and attention today.
Our final speaker in the session is Dr. Alok, who hails from Mayo Clinic in Jacksonville, Florida. He's going to be talking to us on vocal cord paralysis.
Greetings, everyone. My name is Alok Bhatt. I'm from the Mayo Clinic in Jacksonville, Florida, and today I'm going to talk about vocal cord paralysis. I have no disclosures. I do want to thank the program committee, especially Dr. Shalmafis, for inviting me to speak. The objectives of this talk are to review the anatomy, the pertinent structures of phonation, and changes seen in vocal cord paralysis. We're going to review the path of the bilateral recurrent laryngeal nerves, and we're going to develop a systematic approach to the imaging evaluation of a patient with vocal cord paralysis and loss of voice. So what is loss of voice? Loss of voice is dysphonia, or abnormal voice quality. Now, the patients aren't going to come to you with dysphonia. They're going to say, I have a hoarseness to my voice sounds breathy, strained, rough, or weak. First, let's take a look at the anatomy of the larynx. Now, remember that the larynx serves three main functions: phonation, respiration, and tracheal protection. The first key piece of anatomy you want to remember are the true vocal folds, which are the most inferiorly located folds here. Superiorly are the false vocal folds right here, which serve a protective function. And the true and the false vocal folds are separated by the laryngeal ventricle, or this lateral depression here. On the axial image, when you're at the level of the cricoid cartilage, you're also at the level of the false vocal folds. Remember this nice teardrop appearance of the laryngeal airway. So what are the signs of vocal cord paralysis? Here's a patient with left vocal cord paralysis. On this leftmost image, you see medialization and thickening of the left areopaglottic fold. On the second image, dilatation of the ipsilateral piriform sinus. On the third image, dilatation of the left aspect of the laryngeal ventricle. And on the final image, you see posterior medial rotation of the left true vocal fold, giving the so-called sail sign. So 4 imaging findings of left vocal cord paralysis. Now that we know the signs of vocal cord paralysis, let's test ourselves. Which side is paralyzed in this case? On the first image, there's complete adduction of the right vocal fold here. Everything is at midline. On the second image, there's slight dilatation of the left piriform sinus, as well as medialization of the left areopaglottic fold and a little bit of thickening. On the third image, there's dilatation of the left aspect of the laryngeal ventricle. So which side's paralyzed? It's actually the left side that's paralyzed. There's left vocal cord paralysis. And I put this case in here just to remind everyone that you must take a look at the constellation of findings and remember how the images were acquired. These images were acquired with breath hold, and therefore this right vocal fold, it's doing its job. It's completely medialized. It's supposed to be completely adducted. So remember that the fibers of the recurrent laryngeal nerve travel with the vagus nerve, which is a wandering nerve that's going to extend through the neck, the chest, and the abdomen. Lucky for us, our end organ is going to be the larynx, so we're going to focus on just the path of the recurrent laryngeal nerves. Now, when you're looking for pathology for vocal cord paralysis, there are 5 key areas that you want to interrogate, and here they are. You're going to want to look at your brainstem, you're going to look at the jugular foramen, you're going to look at the carotid space, you're going to look at the mediastinum, and then the larynx. So let's first start at the level of the brainstem. Remember that cranial nerve 10 contains fibers of the recurrent laryngeal nerve, which exit at the posterior lateral sulcus in the medulla, and it's a combination of 4 nuclei. Here's this high-resolution T2 weighted image, which demonstrates the 9th and 10th nerve complex that extends out at the level of the brainstem at the level of the posterior lateral sulcus here. Now I put the image on the right here just to remind yourselves that along with cranial nerve 10, cranial nerve 9, 11, and 12 are all in close vicinity, and therefore if you have a lesion of the brainstem or the jugular foramen, you may see multiple cranial neuropathies. So here are 4 different patients, all with lesions involving the brainstem and all with vocal cord paralysis. Let's take a look at our patient on our left-hand side first. On this axial T2 weighted image, you see this heterogeneous T2 signal lesion, which has an internal foci of high T2 signal as well as a peripheral rim of low T2 signal. When you take a look at this T2 weighted image, you can see that there's hypertrophy of the inferior olive as well as hypertensity involving the medulla. And this is a patient with cavernoma causing vocal cord paralysis, also with hypertrophic olivary degeneration. On the second image, the diffusion weighted image demonstrates multiple foci of restricted diffusion within the bilateral cerebellar hemispheres, but look carefully. There's also restricted diffusion involving the lateral aspect of the medulla right here. On this MRA, you see that there is a crescenteric shape to that flap within the left vertebral artery, and this is a case of left vertebral artery dissection causing infarct involving the medulla, causing vocal cord paralysis. On this third image here, you see that there are post-surgical changes within the right cerebellar hemisphere, but there's also nodular masses within the brainstem. You go to the sagittal post-contrast image of the spine, and you see also additional multiple nodular lesions as well as serpiginous vessels. And this is a case of hemangioblastoma in a patient with von Hippel-Lindau disease. Now this last patient on this T2 weighted image, there's multiple foci of T2 hyperintensity as well as one within the posterior lateral medulla. When you look at the brain MRI, there's periventricular hyperintensity as well as T2 flare hyperintensity within the subcortical white matter. This is a patient with demyelinating disease in the setting of multiple sclerosis. So 4 different patients, all with vocal cord paralysis, all with different diseases. Next, let's move on to the jugular foramen. So remember that cranial nerve 10 exits the skull base via the pars vascularis together with cranial nerve 11. Now there are 2 important ganglion that you want to remember. The most important one is the inferior ganglion, which is just below the level of the jugular foramen, which is the exit point of the pharyngeal branches. Now these pharyngeal branches send motor fibers to the pharyngeal plexus, which supply the pharyngeal muscles, the palate, and the uvula. And this can be an important thing to remember when you're trying to localize the lesion, and you'll see what I mean just a little bit later. So let's review the anatomy of the jugular foramen. Here's your jugular foramen right here. Remember that anterior medially you have the pars nervosa, posterior laterally you have the pars vascularis, which is separated by the jugular spine. Here are 3 patients with different lesions involving the jugular foramen. On the leftmost set, you see this lesion that's involving the left jugular foramen, which is predominantly intermediate in signal on T2 weighted imaging, but you can see that there's also internal foci of low T2 signal. When you take a look at the CT image, you can see that there's permeative, moth-eaten appearance of the left jugular foramen, and this is a case of a paraganglioma. On the second image, you see a lesion which is dumbbell-shaped right here, and on the CT image you can see that there's smooth widening of the jugular foramen. Note that the cortex is preserved, and this is a case of a schwannoma. On this last image, you see this lesion that's extending through the jugular foramen, but look very carefully. You see that the cortex is thickened. On a CT image, the findings are confirmed that there's hyperostosis of the bone. So when you see hyperostosis of the bone, you think about meningioma. So here are 3 patients, 3 different lesions of the jugular foramen, all causing vocal cord paralysis. On CT, when you see impermeative, moth-eaten appearance, think about a paraganglioma. When you see smooth widening, think about a schwannoma. And when you see hyperostosis of the bone, think about a meningioma. So how do I find the lesion? Here's a 67-year-old male with a weak voice. When you take a look at this axial CT image here, you see that there's posterior medial rotation of that right vocal fold here. So you've localized or you've lateralized the side of vocal cord paralysis. The patient has right vocal cord paralysis, so that means cranial nerve 10 is involved. Now you're going to look for additional findings, right? So you notice that there is loss of relative fat within the right posterior lateral aspect of the neck, but you also note that there's loss of relative muscle bulk involving the sternocleidomastoid and the trapezius muscle. So now you know that cranial nerve 11 is involved. So when you have cranial nerve 10 and 11 involved, you want to focus your efforts on the skull base, and that's exactly what we did here. On the CT image, the top left, you can see this hyperattenuating mass centered within the right jugular foramen. On CT, you can see that the bone is destroyed. When you take a look at the T2 weighted image, you can see that this lesion is very dark in T2 signal, and there's relatively avid enhancement of the lesion. And this is a case of lymphoma. Next, we're going to descend into the carotid space. So remember that the vagus nerve extends through the carotid space. Now, there are multiple anatomic structures within the carotid space. The one key landmark that we want to remember is that the vagus nerve is centered within the posterior aspect of the carotid space between the carotid artery and the jugular vein. So here are 3 patients with carotid space pathology. On this leftmost set of images, here's a patient with this high T2 signal lesion within the posterior aspect of the left carotid space. On the post-contrast image, you can see that there's homogeneous enhancement of the lesion that has a sausage shape appearance. We already saw this lesion. We're now in a different area, though. This is a schwannoma. This next patient has this heterogeneous lesion within the right posterior carotid space. You can see that there's internal foci of low T2 signal lesion. Look at this classic appearance for this lesion where you see displacement of the carotid vessels anteriorly. And this is a case of a paraganglioma or glomus vagale. On this last set of images, you see this patient that has this infiltrative mass lesion within the left oral pharynx. There's also metastatic lymphadenopathy involving the carotid space. On the parasagittal image, you see the extent of involvement here, and this is a case of squamous cell carcinoma with metastatic lymphadenopathy causing left vocal cord paralysis. Let's look at a patient with carotid space trauma. Here's a 45-year-old female with stabbing injury. Here on this axial CT, you see that there's injury to the left neck. When you take a look at the coronal image, there's a little bit of a focal dilatation of the left distal common carotid artery. You zoom in, and indeed, your findings are confirmed. On the last image, there's posterior medial rotation of that left vocal fold. So this is the patient with left carotid space injury with presumed injury to the vagus nerve causing left vocal cord paralysis. Another patient with carotid space injury, a different mechanism. Here's a 70-year-old male with voice changes. On this first image, there's posterior medial rotation of the left vocal fold, so you've lateralized the side of the lesion. This patient has left vocal cord paralysis. When you took a look at the parasagittal images, you can see that the left carotid artery has this ratty, irregular appearance. On this axial CT image, there's scarring within the left neck. You can see some post-surgical changes. Now, you start looking at the clinical history, and you realize that the patient had a history of carotid endarterectomy. So this is a case of iatrogenic injury to the left vagus nerve causing left vocal cord paralysis. How do I find the lesion? Here's a 62-year-old male with voice changes and tongue weakness. There's a remote history of squamous cell carcinoma, and the patient is status post left neck dissection. So you already know what the diagnosis is, right? It's going to be squamous cell carcinoma. We just have to find exactly where the lesion is. Well, on this first image, there's posterior medial rotation of that left vocal fold. So you've lateralized the lesion to the left side of the neck already. So you're done. So you know that cranial nerve 10 is involved. When you take a look at this T2 weighted image, there's T2 hyperintensity involving the left tongue. Now you realize that the lesion, the infiltration of the T2 hyperintensity involves just the left aspect of the tongue and extends right up to the level of the midline. Now you know that this is not tumor because no self-respecting tumor is going to have a clear demarcation through the midline. Well, now you've diagnosed this patient with denervation changes involving the tongue. So you know that cranial nerve 12 is also involved. Now you look again for some other findings that may clue you into where the lesion is. Remember that I told you that that inferior ganglion right at the level of the jugular foramen supplies pharyngeal branches. We'll take a look at the uvula. The uvula is deviated towards the right side. So now you're going to focus your efforts on the jugular foramen. If you take a look at the jugular foramen, you found the lesion. There's an intense enhancement involving the left jugular foramen right here. You also have the hypoglossal canal that's involved. Look at the normal side on the right side. So this is a case of metastatic squamous cell carcinoma involving the left jugular foramen, causing left vocal cord paralysis. Next, we're going to move into the mediastinum. Now, the mediastinum can get just a little bit tricky because the path of the recurrent laryngeal nerves are different on the right and the left side. Remember that the right recurrent laryngeal nerve wraps around the subclavian artery here and then extends cranially to the level of the larynx. The left recurrent laryngeal nerve extends inferiorly around the aortic arch. Now, the left has a longer course, and therefore it's more susceptible to pathology. Let's look in these axial images right here. The right recurrent laryngeal nerve, remember, exits anterior to the subclavian artery. So here's the right recurrent laryngeal nerve that's extended that exits anterior to the subclavian artery, and now it's going to course towards the tracheoesophageal groove into the larynx. The left recurrent laryngeal nerve is going to exit at the level of the aortic arch. So here's your left vagus nerve here. Here's the aortic arch here. And here's your left recurrent laryngeal nerve that's ascending towards the tracheoesophageal groove to get to the larynx. So there are 3 different patients with mediastinal pathology. Our first patient on the left is a patient that has this nodal mass that's sitting in the periaortic region here. On the PET CT, you can see that there's hypermetabolic activity, which corresponds to the lesion. This is a patient with metastatic breast cancer with periaortic lymphadenopathy. On the second patient, the patient has left vocal cord paralysis. There's dilatation of that left piriform sinus here. On the coronal CT image here, you can see that there's an infiltrative mass lesion within the left mid-lung field that extends into the aeropulmonary window. And this is a case of lung cancer in a patient with smoking history. This last patient has left vocal cord paralysis. Here you have necrotic lymphadenopathy that's involving the periaortic region, and this is a case of lung cancer, also in a patient with smoking history. Let's look at this case. This patient has left vocal cord paralysis, posterior medial rotation of that left vocal fold. If you extend more inferiorly, you can see that there's post-surgical changes within the mediastinum. There's also dilatation of that left main pulmonary artery here. On the coronal image, you can see there's dilatation of that left main pulmonary artery again. And if you take a look, the expected course of that left recurrent laryngeal nerve is going to sort of extend inferiorly here between these 2 areas. So it's not inconceivable that you can have a sort of a crush injury of that recurrent laryngeal nerve causing vocal cord paralysis due to the pulmonary artery aneurysm. Our next patient has this massive aortic arch aneurysm here. If you take a look, again, at the path of that recurrent laryngeal nerve is going to course over and under through that aortopulmonary window here. So this is probably stretching the recurrent laryngeal nerve causing vocal cord paralysis. So a few words about thyroid disease and dysphonia. Any type of thyroid disease can cause change in voice quality. Hypothyroidism can cause myxedema. Hyperthyroidism can cause a hoarse, raspy voice or a vocal tremor. Multinodular goiter can stretch the recurrent laryngeal nerves, and thyroid carcinoma can spread directly into the laryngeal structures. Here are 3 patients with thyroid pathology. On the left set of images, the thyroid is massively enlarged. You can see the thyroid has multiple nodules, some with associated calcifications. On the coronal image, you can see that the left lobe is larger than the right. What's probably happening here is you're probably stretching out that recurrent laryngeal nerve, causing vocal cord paralysis on the left side. The patient in the middle has this infiltrative mass lesion within the left thyroid. You can see that there's also invasion of the trachea here. This is a patient with thyroid carcinoma, which probably has infiltration of the nerves causing vocal cord paralysis. This last patient here, when you take a look at the level of the thyroid, well, there's no thyroid. On the coronal image, again, you do not see any thyroid. So this is another case of iatrogenic injury in a patient with thyroidectomy that has vocal cord paralysis. So we looked at multiple causes of mediastinal pathology that can cause vocal cord paralysis. I predominantly focused on vascular causes and neoplastic causes, but you also want to remember that there are infectious and inflammatory causes that can cause vocal cord paralysis as well. Next, let's move on to the larynx. So the recurrent laryngeal nerve enters posterior to the cricothyroid joints. And now the one key landmark here you want to remember is that posterior cricoretinoid muscle right here. When you have denervation changes of that posterior cricoretinoid muscle, you'll see volume loss and atrophy. So notice the left posterior cricoretinoid muscle right here, which has fatty infiltration compared to the right. Now, this muscle is the main vocal cord abductor. So if you lose abduction function of that left vocal fold, you end up with posterior medial rotation of the vocal fold, as well as medial subluxation of that left arytenoid cartilage. Again, one of the findings seen in left vocal cord paralysis. So here are 4 different patients with either vocal cord paralysis or dysphonia. And this set of cases reminds us that you don't really need to have vocal cord paralysis to have dysphonia. This patient on the left has this infiltrative mass lesion within the right vocal fold here. You can see that the lesion is transglottic, and this is a case of squamous cell carcinoma. The second patient has this fluid-filled, benign-appearing structure within the right paraglottic space, and this is a laryngocele. The third patient has this polypoid lesion extending off the left inferior vocal fold here that was causing dysphonia. This is a vocal cord polyp. This final patient has diffuse edema involving the laryngeal structures. You can see the patient was intubated due to airway compromise and narrowing of the airway here. And this is a case of Reinke's edema in a patient with smoking history. So let's go back to how do I find the lesion, right? I showed you 5 key anatomic spaces to interrogate. We're going to look at the brainstem, the jugular foramen, the carotid space, the mediastinum, and the larynx. And I like to think of it this way. If a patient has dysphonia and higher order symptoms, focus your efforts on the brainstem. If there are multiple cranial neuropathies, look at the jugular foramen. If there's several cranial neuropathies, take a look at the carotid space, right? As you descend within the neck, all these nerves are given off, so you're going to have less cranial neuropathies as you extend caudally. If the patient has a history of smoking or thyroid disease, focus your efforts on the mediastinum and the neck base. And even if you have an absence of all of the above, take a look at the larynx very carefully. So in conclusion, in a patient with dysphonia, you must look for signs of vocal cord paralysis. Once you've lateralized the side, look along the course of the entire recurrent laryngeal nerve. And then there are 5 anatomic areas that we discussed to interrogate. And finally, you want to remember that you may not have an imaging correlate for symptoms. If you don't see vocal cord paralysis, if you don't see a reason for dysphonia, it's okay to put in your reports no imaging findings to suggest a cause for dysphonia. And with that, I thank you for your attention. Please feel free to email me if there are any questions. Enjoy the meeting, everyone.